So next we're in for a treat. I have some really close, good friends today that's going to be presenters, and this is one of my favorites. Please welcome to our emerging technologies session this morning. Our first presenter in this session is the Director Department of Cardiovascular Perfusion. He's an assistant professor and a past AMSEC president. He will be presenting Cardiac Index Impact on AKI study. Please join with me in giving a big welcome, Jim Reagor.
I'll take these with me.
Yeah, do that.
Thank you, Susan. In network TV, back in the day when that was the only thing you had to watch on TV, when a show would struggle, sometimes they would put it in behind a really popular show to try and increase the viewership after that show. So I really appreciate here today the coordinators of this meeting putting me behind a free breakfast and a Nordstrom's gift card drawing in order to help increase my viewership, which it clearly did. Thank you. I have no disclosures which is unfortunate. I can be bought. So if anybody, right? I'll get right into it. We're aware, all of us, that bypass is not good until the presentation that we saw yesterday out of Stanford, which indicated, at least with a very small patient population, it didn't matter how long you're on bypass. Up until I saw that presentation, I'd always say every single presentation or every single publication that I've ever seen indicates that the longer you're on bypass, the worse it is for you across morbidity and mortality. I guess I can't say that anymore. But unfortunately for us, we still showed that in our data. So we'll get to that in just a second. We've seen a lot of stuff about adult data associated with AKI around DO2, and nadir hematocrits, usually below 24. Ranucci, we're all familiar with his 270 number. There's more data coming up around pediatrics, which is something that I'm going to cover today. Zhang's paper in 2021 indicated a threshold of about 350. You don't want to go below that. AKI rates increase there. There's another paper out of France where they looked at DO2 and lactate production and came up with a number around 370. We took a look at flow. The reason we did that is we all know that there's a number of modifiable parameters that you can modify on bypass in order to either improve DO2 or to help out your patients. You can transfuse, you can turn up the flow. And we all know that transfusion is bad. We all try to dodge around that. So with the impact that AKI has on all of our patients, with higher risks of AKI become higher opportunities for more morbidity and mortality, we tried to impact that. So we took a look. I'm going to present two studies here today. We took a look in our first study. We had 3 different surgeons, and 2 of them utilized by preference a target flow of a 2.4 cardiac index with a nadir crit of 28, and the third took a look, had us flow at a 3.0 cardiac index with a nadir crit of 25. We ended up taking patients that all had bypass, of course. Our inclusion criteria was that they had to have a bypass run, of course, and that they were less than 18 years old. We excluded a number of patients based on the fact that they maybe had circulatory arrest or somatic arrest with ACP, if they were a procedure that was not a stat ranked category by the STS, if they had preoperative AKI, or of course an incomplete data set. And the other thing that we looked at, and the most important piece here for the exclusion criteria, is we excluded those patients which didn't actually get that 2.4 or that 3.0 index. So if during the bypass run, for 10% of the bypass run, if you were less than, had flow less than 10% of the target or more than 10% of the target for a total of 10% of the bypass run, we threw you out. because we really wanted to look at those patients that actually got the 2-4 index or actually got the 3-0 index. The conduct of perfusion at Cincinnati Children's is virtually the same. We've done a lot of work within our department to minimize variation between the perfusionists. Our surgeons don't care at all who sits behind the pump because our outcomes are the same. We practice pretty much the same. So the only main difference between these two groups, of course, was the cardiac index, the flow strategy, and then also one other piece. As I mentioned, there's 2 surgeons in the 2-4 cardiac index group. And of those 2 surgeons, one of them allowed us to muff and the other one did not. In the 3-0 index group, that one surgeon did allow us to muff. So we didn't really think that muff would have an impact on this particular study. But in order to validate that that was true, we took the 2 surgeons in the 2-4 cardiac index group and compared their rates of AKI. The p-value for that number, or for that analysis, was 0.91, so they're virtually identical. So we pretty much threw out the possibility that difference in the conduct of bypass or the management of our patients throughout the course of bypass didn't have an impact. The cardiac anesthesia teams were virtually the same throughout in the way that they managed patients, and then also the stay in the ICU. They were all managed the same way, basically based on their defects as they returned to the ICU after surgery. So this is the data that we collected, and the thing to note here is we looked at DO2 and collected DO2 every second throughout each pump run, and we looked at it a little bit differently than some of the studies have in the past. And the way we collected the data is we looked at the lowest sustained or maximum sustained DO2 for 3, 5, 10, and 15 minutes. So wherever you fell and maintained that lowest number, we collected that value, and that was the value that we analyzed throughout the study. And we ended up landing on the 3-minute value because that had more granularity than the other sections of values that we looked at, the 5, 10, and 15. So we define mortality the same way that the Society of Thoracic Surgeon does, with a survival post-discharge from the hospital and 30 days post-intervention. We use the KDIGO criteria, serum creatinine criteria, to determine whether or not they had AKI. We looked at the most recent creatinine value prior to surgery, and then compared that to the peak creatinine value within 48 hours post-surgery. We had a total of 920 patients. 516 of those were thrown out because of that window, making sure that they met that 2-4 or 3-0 cardiac index value throughout greater than 90% of the case. A few didn't have stat mortality or stat category ranks, and 7 of them had incomplete data sets. So that let us take a look at about 235 patients. So getting to the results, the demographics, there was no difference in any of the demographics. The weight, the age, the BSA stat category, none of that was different, which is a good thing, because if there was a difference there, then maybe that could affect our data, but our groups were the same. Average cardiac index and minimum hematocrit on bypass were significantly different. That's a good thing, because if our 2 groups weren't significantly different, then we wouldn't have a valid comparison either. There was no difference in the lowest sustained core temperature, packed red blood cell transfusions, or hematocrit just prior to bypass, and there was no difference in bypass times within the 2 groups either. Where we did see a difference in this first study, other than the 2 study variables, was urine output and cross-clamp time, and both of those were greater in the 3-0 cardiac index group. Now, looking at the outcome variables, we did find a lower rate of any stage AKI for the 3-0 group as was compared to the 2-4 group. But that difference was primarily associated with stage 1 AKI, as there was no difference between the 2 groups related to mortality, ICU length of stay, time of extubation, or AKI stage 2+. And while there was no difference in the ICU length of stays between the 2 groups, we still did show the same information that we get out of a lot of other studies, which indicated an increased length of stay with stage 1 AKI, 2 and 3, and our length of stays were 2, 4, 5, and 11 days, respectively, associated with none through stage 3 AKI. So you stay there longer, which is just a validation of all the other great studies that have been put out there if you end up with AKI. As we all understand, as I've mentioned, there's two significant components, to oxygen delivery, cardiac index, and hemoglobin. So we decided, based on this study, we were just going to turn up the flow. And so all of our patients, regardless of what temperature we cooled to, what procedure they're having, and how old they were, they all get a 3.0 cardiac index. And this was the only difference here was that we changed that 3.0 index, because we've always been what I would consider a high flow institution. If your target index was 2.4 or 3.0, we stayed there regardless of your temperature. If you're 18 degrees, we're flowing a 3.0 index. We very rarely modulate the flow based on temperature. Occasionally, in rare occasions, we might have to turn down the flow if the surgeon's getting flooded at the field because it's a case with a lot of collateralization or something of that sort. But we're almost always at those higher flows. And we have a lower limit now with our 3.0 index of 2.4, which is one of our practice performance metrics. So we really try not to drop below that 2.4 at all, even if we are targeting the 3.0. And again, we went to the 25% hematocrit as well instead of the 28. Now, most of the time when I talk about this, one of the main questions I have from pediatric perfusionists is, if you have to increase your flow, if you're going to that higher index, do you also have to increase your cannula size? Because surgeons get really cranky when the cannulas are bigger than the hole they're working in, right? And that can happen a lot of times, or it can be a burden a lot of times for them to work around all the pipes that we need to put in there to do our job. So this data kind of serves as a shameless plug for the PD Perform Learning Network, which I'll also be giving a presentation on tomorrow. So we can find out some more information about that if you like. But all this shows you is Cincinnati Children's is a column with the star at the top. And it shows you that basically we don't use cannulas any larger than any other centers. Our population for neonates, which is what I'm showing here, which of course is the smallest patients and the largest impact for the cannula size, we use 10, 12, 14, and 16 size cannulas depending on the procedure for venous cannulation. And this really compares quite nicely with the other centers participating in PLN, some of which using up to a 20 French venous cannula. And then here is the arterial cannula size that we'll use. And again, the star represents Cincinnati Children's. And here we all the time for this size patient population, the neonates use a 8 French cannula. And that lines up very well with the rest of the population here that participating in PLN, with a couple of centers actually using a 6 French DLP cannula on occasion. So we implemented this 3.0 index with an ATER crit of 25, and we moved on down the road for a couple of years, and we decided to look at the data again. And what we looked at this time is we took the previous set of patients for one surgeon who is still at our institution, and we compared those patients with the new era patients from his particular cases. So we have eliminated this time the possibility of any confounding issues with different surgeons. We had basically 130 patients from the previous study and compared them to 130 patients in the new era, which was around 2021 to 23. We had the same exclusion criteria, the same conduct of bypass. ICU management hadn't changed significantly, and anesthesia management in the OR also stayed the same. And again, like I mentioned, this time though, same surgeon to same surgeon in the two different groups. And this is what we found. In the 2-4 group, which is on the left, and the 3.0 group on the right, again, there was no difference in the demographics or the case mix between the two groups. And also, again, we saw a difference in our cardiac index, with no difference, though, again, in pre-pump hematocrit or the pump times. And like in the previous study as well, we saw a difference in clamp times between the two groups. But unlike the previous study, there was a difference in blood transfusions, which is really the one conduct variable that differed significantly between this study and the last one. Where it starts to get a little weird is we did see a difference in urine output in the previous study, but we did not see a difference between the two groups in this study. But that might be because we also didn't see a difference in AKI, which quite clearly is not what we expected. We changed our practice based on our previous study to go to the 3.0 index because we previously showed that we had a significant reduction in AKI. And while, as you can see here, while it's not a significant difference, we actually saw a trend towards better outcomes related to AKI in the 2.4 index group. So immediately, we all became very confused. Some people more so than me, because I kind of stay there in that state anyway. But what I want to show you over the next few slides, I want to preface with this. This is terrible data. The results are not significant. The confidence intervals that you're going to see on these graphs are incredibly wide, and we don't recommend changing anybody's practice based on what we're showing here. All this data is going to tell us is we got to look at a lot more data. But there are some interesting indicators and some interesting trends that I'm going to share with you over the next 4 slides, and hopefully encourage people to take a look at this closer. So this slide you see here, this is all of the factors put into one risk model: age, sex, weight, stat category, blood transfusions, the whole kit and caboodle. And we really see basically kind of what we've seen in some of the adult literature and the other pediatric literature. And you can see a deflection on the low end that starts there around 300, that starts to increase the rate or your odds of getting AKI, and then a little bit of a deflection towards the top end when your DO2 gets above 350. When we look at just age, we see pretty equal risk models. So this is a risk model for AKI based strictly upon age. And for patients that are less than 14 months old, which correlates to the published data for the younger patients, but when you get to be a teenager, the risk seems to really increase greatly over once you get over 300. As you can see there, the black and the gold lines represent kids less than 13 and also less than 13 months old, and higher risk towards the lower end of DO2 delivery, and then it plateaus out to where your risk isn't that bad at the higher end. But then that blue line is teenagers, and they look like adults towards the lower end with a deflection around that 270 number, but then really starts to shoot up when you start getting over 400. And so again, that's an interesting signal. Have no idea why, but it's there. In this model, we're looking at, this is the 3.0 and the 2.4 index groups alone. And like I said earlier, we saw an indication in this study group that the 2.4 was better, and that shows up here in this model as well, with the black line being the 2.4 index group and the 3.0 being the gold line. And then finally, a model that did kind of make sense until yesterday with the Stanford presentation, and this is the longer you're on bypass, the higher your risk of AKI at baseline is anyway, with the black and gold lines there being lower pump times and the blue line being longer pump times. So with these results, we kind of started to speculate why. Was there an impact due to the difference in the eras? Did something change that we're not aware of between the 2015 to 2018 data and the 2021 to 2023 data? Was there a higher acuity patient population? We don't really think that's the case because there was no difference in the stat category mix between our two patient populations across the two eras. And then was the DO2 just too high? Did we push it over some limit there that we're not aware of yet that might cause an issue along those lines if the DO2 is too high? Is there a range? Is there a low and a high end? And the last thing, though, is the transfusion rates. And this might actually be the issue with this study. As I noted earlier, our transfusion rates for this patient population, the new era patient population at 3.0 index, was significantly higher than our previous study. And we all know that transfusion rates increase the AKI. So that is most likely the cause of this. And so we're going to have to delve into it a little bit further. And that kind of goes into the last thing, which maybe we just didn't have a big enough N for this population. And we need to just grab some more patients and look at this a little closer. So maybe there's an upper limit to DO2. The question that I started out with, is there a limit to the cardiac index? I'm sorry, I can't tell you if there is or not, based on this data. We did kind of validate the data at the lower end that we've been seeing around that 350 number, but then a significant increase over the 400, especially with the teenage groups who, if any pediatric perfusionists out there know that teenagers just don't behave well on bypass anyway. But we clearly need more data to be able to make that determination. So thank you again for having me, and I'd be really happy to answer any questions.